Like Dr. Nicholas said, my name is Colleen O'Connell, and I'm one of the nurse practitioners in the MS clinic. And I have been, I know I look like I'm 16 years old, but I started at Ohio State. I did my undergrad and master's at Ohio State, worked at the MS clinic at Ohio State until the building opened up in 2015, and I've been here ever since. Thanks for joining us this morning. This morning I'm going to talk about multiple sclerosis and smoking. I originally chose this topic a few months ago out of curiosity and to gain a better insight into the tools that we can provide patients who are smokers and they are interested in quitting. We know smoking is a bad habit, and we want to make sure we are giving them the most effective tools. This is hard to press. Oh, big one, okay. So this morning, my objectives will be the following. I'm going to talk about the negative impact that smoking can cause. I'm going to talk about the approved medications available, and then I'm going to talk about 2 counseling options available. Cigarette smoking remains the most common cause of preventable mortality and morbidity in the world. We know smoking can lead to premature death, and we also know it can cause a lot of other health problems: cardiovascular disease, lung diseases, and cancers. We know smoking literally and figuratively can burn a hole in someone's pocket. And so, obviously it depends on the brand, the type, and where you live, but the average pack of cigarettes in the US costs about $8 a pop. In 2018, smoking contributed to $600 billion in healthcare costs across the United States. A lot of money for an already strained healthcare system. There was a study in Sweden that was published in March of 2022 that hypothesized that 13% of cases in Sweden possibly would not exist if smoking wasn't a thing. And obviously we're not Sweden, but knowing the prevalence of smoking, knowing the prevalence of MS around the world, these are staggering figures. Specifically, MS. We know smoking is not good for our MS population. Number one, it can increase the MS risk. Research indicates that one exposed is 2 times more likely to develop MS, whether they are active smokers or they have exposure via secondhand smoke. And oftentimes a patient will come into our clinic and ask, how can I reduce my children's risk from developing MS? And we will always say, do not let them be around smoke. Number 2, smoking worsens the disease course. Smokers tend to have higher EDSS scores, and the EDSS score is a scale that we use to measure disability. And we see that smokers, the higher the EDSS score, the more disability someone has. In regards to the MRI findings, smokers tend to have increased brain atrophy, which is shrinkage. And also they can have increased risk of active lesions. An active lesion is one that's enhancing and has inflammation. And when someone has an enhancing lesion, they can have relapses and increased neurologic symptoms. Number 3, smoking can potentially decrease effectiveness of certain disease-modifying treatments, such as interferons and tysabri. Smokers tend to have a higher increased risk of developing antibodies to these medications. And when someone develops an antibody to a particular drug, that medication may no longer be effective. Smoking, again, kind of like I said in a previous slide, can lead to other comorbidities. We know patients, MS patients tend to do a little bit worse when they have other comorbidities. And finally, smoking can increase infections, most commonly upper respiratory infections. And when an MS patient has an infection, there can be a transient worsening of their neurologic symptoms. The National Institute of Health, or the NIH, periodically evaluates smoking cessation rates. It was last done in 2015. To summarize, approximately 2/3 of smokers are interested in quitting. About half of smokers did report that they did receive advice from a healthcare professional within the past year to quit. And about half of smokers did attempt to quit in the past year. Unfortunately, less than 1/3 of those who tried to quit used an evidence-based intervention or treatment. So unfortunately, less than 1 out of 10 were successful in their quit attempt. What this tells me is that we need continued strategies to increase these statistics. As a healthcare provider, we need to continue to assess someone's readiness to quit, and if someone is ready, to provide them those effective tools. On the flip side, as someone who wants to quit, we want you to stick with the plan, follow the plan, and if there is a little bit of a hiccup or it doesn't work, let's go to plan B. Currently, there are 7 FDA-approved medications to help someone quit smoking, 5 of which are in a medication class called nicotine replacement therapy, or NRT, and then we have 2 other oral options. In the next couple of slides, I'm going to talk about all of these options very briefly. Nicotine replacement therapy, again, or NRT, actually does deliver some nicotine, but it does not have the chemicals and the toxins that tobacco usually has. It's not recommended for those who are currently smoking or using any other form of tobacco, and it probably is not best to use with someone who has unstable cardiovascular disease. The first NRT I'm going to talk about is the patch, which is probably the most common or most popular option. This one is the long-acting option, and it generally stays kind of in a steady, continuous state in the bloodstream with the hope that it will prevent cravings from occurring. These are 24-hour patches, and they come in 3 different doses, a 21, a 14, and 7. Generally, the heavier the smoker, we would want you starting at the higher dose. Usually we ask that someone starts at whatever dose that we decide for 6 weeks and then taper every 2 weeks, and with the ultimate goal that they will quit. Again, it is 1 patch that should be used 24 hours and then reapplied the following day. Some people do report some vivid dreams, and it would be okay to possibly, it could be removed before bed, but we just want to instruct patients to reapply a patch as soon as possible when they wake up. Irritation can be common at the site. Upwards to 50% could report. Usually this is very mild and not very bothersome at all, but if so, usually an over-the-counter like hydrocortisone cream can eliminate it if it is. Probably the easiest form to use, but often one of the drawbacks is sometimes patients feel like they have an underdose sensation. The next 2 I'm going to group together just because they're very similar in regards to dosing and side effect profile. And this would be the gum and the lozenges. And these, again, come in 2 different doses, a 4 milligram, 2 milligram dose. Usually the heavier the smoker, or the smokers that usually have their first cigarette pretty much right when they wake up, I would recommend doing the higher dose. Usually when we use this one, we would recommend that they use 1 piece every 1 to 2 hours for the first 6 weeks, and then kind of reduce by spreading out the interval. Then maybe 1 piece every 2 to 4 hours for a few weeks, like 2 weeks, and then every 4 to 8 hours, with the eventual goal to taper. With the gum, the behavior is to kind of chew and park. You don't have to chew for 30 minutes, but we ask that it kind of stays in someone's mouth for about 30 minutes. Might not be the best option for someone who has dental concerns. With the lozenges, again, it's something that we shouldn't chew, just kind of let it gradually dissolve in someone's mouth. Probably some people do report some gastrointestinal side effects, so we have to watch for that. Recommend no drinks 15 minutes before or after. And again, this can be used in isolation by itself, but oftentimes this can be paired with the long-acting, like the patch, to curb kind of those cravings. The 4th NRT is the inhaler. and this is absorbed through the oral mucosa. And this is intended to mimic the hand-to-mouth behavior. This is a device that generally people have a continuous puffing, about 80 puffs in about a 20-minute time span. Usually we are recommending at least 6 cartridges per day, but generally speaking, a lot of times people are going between 6 and 16 a day, which kind of makes sense because, you know, a pack-a-day smoker might, you know, use 24 cigarettes. Again, ultimate goal is to eventually taper down. And finally, the nasal spray is the last option. This delivers the nicotine the fastest out of all of the options. And a dose is a spray to each nostril. And they do recommend that you begin 1 to 2 doses, so 2 to 4 sprays per hour for the first 6 weeks. So this might be more effective for the highly dependent patients, the heavier smokers. Again, this might not be the best option for someone who has an airway restrictive disease or nasal disease. And again, the frequent use, just knowing how often someone has to do that, might cause issues with compliance. And shifting gears, bupropion or Wellbutrin or Zyban is an oral option. This is an antidepressant, and usually the recommendation is for, if we decide to use this medication, is let's pick out a quit date about 1 to 2 weeks before we start this agent. Usually this medication is started once a day over a couple of days, 3 days, and until we get to twice-a-day dosing. Generally, the duration of this course is 6 to 12 weeks, but it can be taken up to 6 months for maintenance. After 6 months, we probably should evaluate if you know, maybe we need to look at another option if this isn't successful. This medication is, again, an antidepressant, so it might kind of kill 2 birds with 1 stone if we have some undertreated mental health concerns. But I caution that it probably isn't the best option if someone if they're anxious. Also should not be provided or prescribed if someone has a seizure disorder. Oftentimes I'll have patients concerned about weight gain after they quit smoking or want to quit smoking, and this medication might have some weight loss properties. And finally, varenicline or Chantix. Again, this is an oral agent. Typically, for first week, we start kind of a slow taper up to twice-a-day dosing. The course of duration is a 12-week program, but can be continued for 6 months. If someone has kidney or renal impairment, we might need to reduce the dose out of safety. There is a black box warning that it should be used with caution with someone who has a strong psychiatric history. One of the side effects that I always talk about, and I have heard a lot of reports, is sometimes there can be some vivid or bizarre dreams associated with this use. And I always, one big education piece that this medication to help avoid gastrointestinal side effects is to take after eating with a full glass of water. And if you know me, I am a water drill sergeant, so any medication that promotes fluid intake is good in my book. So to improve the success, we also know that using combination therapy also might be successful. Kind of what I already hinted towards earlier, that the long-term NRT, the patch, and short-acting might provide us extra benefit. We also know bupropion and an NRT is also helpful in terms of quitting. Unfortunately, varenicline and NRT didn't really have any added benefit when used in combination. However, there is some thought that varenicline might be the most effective agent for smoking cessation. But again, we have 7 options, and the nice thing is we can tailor to someone's a patient preference and to take into consideration side effects or other health concerns. And to go the extra mile, in addition to using a smoking cessation medication, we do recommend a counseling piece. And there are smoking cessation programs available. And this is kind of the talk therapy where professionals work with you to kind of figure out what your trigger is and then try to break that habit. And Ohio Health actually has a smoking cessation program. It's a 6-week program across several locations around the system. It can be in person, it can be virtual, just depending on the location and the time of the year. The cost is free. Typically each session is about 1 to 1.5 hours. And anyone in the community, spouses, friends can sign up with you. This is kind of a map of the central Ohio area, and as of right now, Ohio Health offers it in 12 different locations. And I think also in recent years with the Zoom and the telemedicine option, that's become a very popular option. If someone is interested in this program, we would encourage them to contact us with the phone number. But I'll be honest with you, if you just Google Ohio Health Smoking Cessation Program, it will come up right away on your search. There are 2 numbers available. They go to the same place. And I'll be honest with you, when I called them, it's kind of always nerve-wracking because you leave your name and it'll prompt you to probably leave your name and your contact information. You're like, well, where is this really going? But they have been very responsive the few times that I have called them to get some information. Typically, they'll call you back within a couple of hours. Again, your provider probably can't place a referral. It just won't go anywhere, even though there is that option. They want you to initiate the phone call. The other counseling option is the Ohio Tobacco Quit Line, and their contact number is 1-800-QUIT-NOW. They offer 5 sessions, either online, phone, or a combination. They also have a 24/7 text and emergency line if someone feels like they're in a crutch and they want to talk to someone about, I want to light a cigarette. And one of the other positives is that they can offer several weeks of free nicotine replacement medications, just depending. Again, we know smoking can be one of the hardest things someone does, but we know that it's not impossible. And here at Ohio Health, we have a team that will help you any step of the way.